we're looking after 2 or indeed 3, 4, 5, 6 patients. Mum comes first. In this country, the legal framework is clear. The unborn baby, the fetus, has no rights in the UK law. And then there's everyone else. So there's all the other people who have an interest and an influence on this decision making. So the role of the family, birth partners, other non-clinicians, society's perception, the voice of social media. There's actually a lot of influences on the person making these decisions. And as I've said, there is risk. Come on to some mortality stats in a second. And I think rightly, we don't tolerate adverse outcomes in what we do, because we think we should keep everyone safe. And so there's some competing things in there that don't quite sit with each other. And I think our job as healthcare professionals involved in maternity is to try to rationalise that and do our best to navigate those tensions. So this slide is about the women who died in the last triennium that's been reported, which is 20 to 22, and showing you that the number of women who had other things going on. So the scale up the y-axis is the percentage. So more than half of these women, use the pointer? No. More than half of these women had a pre-existing medical problem. 5% of them had a heart problem. Quite a bit of IVF in there. 30% were obese. Lots and lots of them had previous cesarean sections. That's relevant when we think about choice. So actually these women had multimorbidity, the women who died, and therefore we need to be cognizant of that when we're making these decisions and actually realise that unfortunately all of the women and the babies that we're looking for are not necessarily well. This is a sort of scattergram of who has an influence or an interest in what goes on with this pregnancy and this birth. Obviously, there's the pregnant person, her partner, maybe the wider family, unborn babies, other caregivers, doulas, and then there's all the other stuff that comes into play in our decision making and what we perceive as right or wrong, cultural background, religion, language barriers, and social media, that ever present thing in all of our lives. You could add to this diagram that, you know, that was my thoughts about it. And it's not to say that those people or those factors having an influence is unimportant, but I think understanding it is really important when we're trying to help women to choose what happens around their pregnancy and childbirth. So maternal mortality, we're really lucky in this country, actually. We don't have a lot of women die in childbirth. When it happens, it's terrible, but it is a small number. So the latest maternal mortality ratio has actually sadly gone up slightly. Even when you get rid of the COVID deaths, it's about 13.5 per 100,000 maternities. We're very, very good, as you would, I hope, expect, at collecting maternal mortality data in this country. And so hopefully we absolutely count everybody. Obviously, that is different worldwide. That doesn't happen everywhere. Not all maternal deaths will be even counted, leave alone reported. And so if you use routine sources, essentially death certificates, there's actually about half that. It's about 6.5 in 100,000. So obviously you use that for your international comparison, because that's only fair. Global maternal mortality ratio in 2020 was estimated at being 223. And in low-income countries, it's 430. The hospital that I go and work at in Uganda delivers a very, very similar number of babies to the JR, about 8,000 a year. They have about a maternal death a week. We probably have one every 2 or 3 years. So it is completely different. And that tells you that inherently this is not a particularly safe business, and something is going on that's making it safer in a high income, high resource setting versus a lot of low resource settings. And actually a lot of that is skilled birth attendants. If you read any of the international literature about what makes childbirth safe, it's giving birth in a health facility with someone who knows what they're doing, usually a midwife. And actually that, yes, there's sanitation, yes, there's antibiotics, yes, there's drugs to fix postpartum hemorrhages, but it's the people and it's the facilities that make the biggest difference, and the WHO is really, really clear about that. This is the causes of death in the UK, and essentially I'm just showing it to you to show that half is non-obstetric. So half is the pre-existing heart disease, the stroke, the epilepsy, the something else. It's not being driven primarily by the pregnancy. Again, underpinning the point that we are not, unfortunately, necessarily looking after well people. And this maybe is a little bit more of an illness than people care to acknowledge. Perinatal mortality in the UK, just to touch on again, we're lucky, it's low. We hope it's lower. We're aiming for it to be lower. That's always the aim. The extended perinatal mortality rate in the UK is about 5 in 1,000 births. About 3.5 of that stillbirths and about 1.5 is neonatal mortality, compared to globally a perinatal mortality ratio of 53 in 1,000 live births, obviously slightly different denominator. The leading causes of death are actually quite similar, and they have fallen over the last decade. And finally, in this section, as I said, it's not tolerated when it goes wrong. There's all sorts of investigations. There's internal investigations, there's external investigations. People end up in the coroner's court. You won't find a senior obstetrician who hasn't had some form of external investigation, hasn't been in the coroner's court giving evidence, whether or not they were responsible for what went on. This is the reality of our working lives. Now, I think the women and babies we look after is as important as anyone, but we need to paint this picture in the context of how much trouble we get in as individuals when it goes wrong. And that is just the reality of it. These are all headlines from reputable news sources, the BBC, Sky, ITV. These are not the red tops, and this is not social media. I could show you a slide that was much worse if I did it that way. But this is just to say that even in, what we would regard as the, mainstream media, that this is what's being published about maternity services in the UK at the moment. We're going to hand over to Kate to start us on the different roles of the maternity MDT. That's definitely enough talking from me, and we'll talk about the different perspectives on the problems that I've hopefully started to outline.
You can keep the clicker if you like.
Oh, sorry, multidisciplinary team. So the fact there are different people, no, very right.
We've tried to highlight the main ones that we're going to touch on in here. So the midwife, we have separated it down into midwife and the coordinator in the delivery suite, because the role is slightly different and their input is slightly different. And then obviously our obstetric colleagues, our anesthetic colleagues, scrub nurses, and then our neonatal colleagues, ICU, which thankfully hopefully don't have to involve as much, but every single one of them sort of links together, and they all have their own role in the shared decision-making sort of skeleton, so to speak. Move on one more. So I'll focus slightly more on the midwifery side, because it's the bit we know a little bit more. And I think they are very much...
Sorry, just before you go on, what is a midwife coordinator? Forgive me, but you're...
So it's a midwife who is supernumerary to the rest of the midwives on shift, and they maintain helicopter oversight.
Right.
They will go in and assist other midwives in births. They'll ensure that the obstetric people are getting elements that they would like in terms of moving to theatres, and they have oversight and try and maintain the safety of all the women and birthing people on the ward, rather than the one-to-one care the other midwives will be giving. So in terms of the midwife in the room, there's very much sort of a narrative that midwives are there to be advocates for women and birthing people. And I think that is absolutely true and fair to say. But I think there's a big difference between being an advocate and getting a woman or birthing person what they want. So I think sometimes they get a little bit blurred, and I think there are a number of things that blur that, particularly for midwives in rooms, and I don't think it's spoken about enough, is they will very often provide one-to-one care for 12.5 hours straight. And I challenge anybody to find that something that's easy to do. And if you're going to try and maybe broach a topic of conversation with the woman or birthing person that you're looking after, that maybe you don't necessarily feel a decision they are seeking is necessarily safe, based on evidence or in her best interests, knowing that then you're going to have to spend quite an intensive period of time with them following that, that's definitely something that can influence, consciously or subconsciously, conversations that midwives have in the room in front of the women and birthing people they're looking after. And also that goes to surrounding people. So it may well be that I decide I'm going to have a baby and I do not want an epidural ever in labour whatsoever. So I tell my partner I never ever want an epidural ever in labour. And I go in, and then maybe there's sort of changes and decisions that are happening during that time, but that partner has decided my job is just to make sure she does not get an epidural in labour. And having to navigate that during this time is also particularly difficult when it comes to making shared decisions. They are responsible for overseeing student midwives, and that comes with its own level of play. How well do you know that student midwife? How much indirect or direct supervision are they getting? What kind of conversations are they having? And it's quite an intimidating world for student midwives these days, I think, because of the litigation, because of what you read in the news, and therefore there is fear about having challenging conversations quite often. And I think that often therefore falls to our midwives in the rooms to have those conversations, and maybe the experience isn't coming through in the way we had previously done. But I think there's an element of fear in ensuring that safe care happens and you don't cause reason for complaint to occur. And also previous experience is really, really important. Most of obviously what we do is evidence-based, but there is an element of anecdotal or previous experience that comes into this. And there used to very much be, for example, and I hope I don't offend anybody in here, anybody who is redheaded or ginger, they're going to bleed more. They're going to bleed more. So you just have to make sure you're prepared that they might have a PPH. Pretty sure there is no evidence for that. Please do correct me if I'm wrong. But people pick up these theories and these sort of like experiences they have of their own and create their perception of what might happen. And that definitely is something that, again, consciously or subconsciously plays into decision making that we make with women and birthing people in the room. You also now, I think, in this day and age, it has to be noted, is that due to the staffing pressures that midwives are absolutely feeling, an element of that will come into play. How many people have they looked after on that shift before getting to this person? Were they actually supposed to be in a different job and they've been pulled from the job they're supposed to be doing to come and look after somebody in a room, and therefore haven't come in with the headset of, I'm going to look after this person start to finish? Have they come from a previous really difficult case and therefore they're coming in a bit more defensively to this case? All these sorts of things really contribute, rightly or wrongly, to the shared decision making that ends up occurring. If you're a coordinator, it is slightly different, and it's probably easier to make the harder decisions because, as I alluded to before, you're not in the room sort of continuously with that woman, and therefore you can go in and have challenging conversations that actually you can then step away and go, I've now left it with that midwife. And that's really, really hard, but probably is slightly easier for them to do. When they're looking at it, though, they need to look at the safety of everybody. So what are everyone's clinical needs? What staff do they have available? What does the rest of the MDT want? What does the woman and her birthing partners want? And what does that midwife need? And every single one of those prongs has to come with an equal level of weight in order to keep everybody really, really safe. The prioritisation can be really, really hard, and there is now a lot of noise that comes with shared decision making, which is unfortunate, but it's definitely true. And there's an element of how much do you complain versus how does that affect the prioritisation list, whether it should or shouldn't. That does come into play a bit more. We will talk about that a little bit later. Also looking at workflows, and there are conversations I've had that are, well, if so-and-so picks this decision, that only takes a couple of hours, whereas they pick this decision, that takes 12 hours. And how does that impact on the ongoing list of care for the elective sections, for the inductions of labour? And what does that then look like in the grand scheme? And a lot of these conversations are really unpleasant and uncomfortable to have, because it's not necessarily, as Alex said, you want to give everybody the perfect care, but what you actually want to look at is trying to give everyone safe care, and anything we can do on top of that these days is ideal. And then they also have to consider staff allocation. So we are in a very junior workforce at the moment, and we probably have some of our very experienced midwives in the room who will attest to that. And we are gathering midwives from all over the globe now to try and help mitigate the midwifery problem that we have. But that comes with its own element of how we support these midwives to feel that they can advocate, they can help with the shared decision making without sort of feeling that there is a distinct hierarchy. Hierarchy does keep people safe to some extent, but there's also an element of everyone having an equal voice too, and finding that fine balance can be quite hard sometimes, particularly when it comes to shared decision making.
Cool, so I'm going to talk a bit about obstetrics. In general, for most labour wards, we have an obstetric registrar, and an obstetric consultant, and an obstetric SHA, who is the most junior member of the team. And generally speaking, the registrar and the consultant are making most of the decisions with the patients that we look after on what we're doing, how we're doing it, where we're doing it, etc. And so to talk about registrar, I would say that in most trusts, the registrar is the one that does a lot of running around into rooms, in and out, chatting to patients, talking about their options, doing cesarean or whatever it is that needs to be done, coming back, in another room, in, out, in, out, in, out. We run around a lot. We make lots of decisions on a shift. I think as you get more senior, as you become a senior registrar in particular, and in particular out of hours, you start to have more of an oversight of the whole labour ward rather than just, oh, look, this patient needs a review and I'm going to go in and I'm only going to focus on this one. And that's an important skill and a difficult skill to master both at the same time. And it varies depending on how busy your labour ward is at that moment and in general. Managing the team, so out of hours, particularly if you're a senior registrar, you'll have a team of people that you need to keep safe and happy and working hard and well fed. Well, it's all about benefit if you manage it. And again, depending on how busy it is, we may be more or less successful at that. The skills of the registrar, the skills of the other registrar working with them, the skills of their SHO, and also their training needs. So we all have a responsibility to teach and to train. And these are all conflicting priorities sometimes on a labour ward. And what I will say about all of these things is that as it gets busier, all of this gets harder. So training is trickier to do, teaching is trickier to do. Everything, the decisions that you make are much harder at 6 p.m. after a busy day than they are at 8 in the morning when you've just arrived. And lastly, similar to when we talked about midwives, all of us are coloured by our previous experiences. And you'll find that if you came to work last week and had a terrible uterine rupture where the baby was in the neonatal unit, the mum was in ITU, it was just awful, then the next week when you arrive and you've got a patient who's had a previous cesarean section, who wants a VBAC and he's been a bit stuck, you feel more nervous about that person being on your labour ward. We have a consultant, or as I like to call them, the boss. The consultant might be present during the week or at the weekend in the day on the labour ward. And if they are, then their role is usually to take the difficult decisions and to have oversight of the whole labour ward. Out of hours, they are often at home. So overnight, they'll often be at home and you can call them. And if you call them, it's usually to ask a difficult question when you've just woken them up at 3 in the morning. And it's usually to ask a difficult question with a bit of an agenda about what you want. And so how you ask the question might depend on what you want the answer to be. But ultimately, the buck stops with them. So the reason you're calling them is because everything that happens on this labour ward is ultimately the responsibility of the consultant. They manage competing priorities in the team. They often do 24-hour shifts where they'll be present for 12 or 14 hours or longer, and then they'll go home and be on call by phone. They will allocate tasks. So if it's busy, if they're physically on the labour ward, they will generally decide who goes where and does what. And like I said, the buck stops with them.
And I guess the one thing I'd add as a consultant is you're also often making some decisions that are remote from the labour ward. So sitting in an antenatal clinic when the woman says, I would like to do the following thing, whatever that thing is, and whether that's you view that as sensible, reasonable, otherwise a little bit out of guidance, but not too bad. Your conversation with that woman, the discussions that you have, the promises that you make in inverted commas have impact, and they often have impact on other people. So what I say to someone about what I think is reasonable or not will impact on midwives. It might impact on the community midwives who are going to support the home birth in the woman who's had a previous cesarean section. It might impact on Nadia when she gets called up to the midwifery-led unit at 4 o'clock in the morning because someone's having a horrible shoulder dystocia because I said, sure, yeah, I know you had a shoulder dystocia last time around, but you can deliver on the supplies, that'll be fine. And I'm being a little bit facetious, but the point is that I think we need to be mindful as consultants that actually it's often not us that has to do the sort out of the thing that we've said yes to. Now, that doesn't mean we shouldn't agree, but it does mean that when we're making those decisions, we do need to think about having broader conversation with wider members of the team about those decisions, particularly when we're falling outside of guidance, so that people are there with us and we know who's going to do what. And the midwives who run the midwifery-led unit or the home birth midwives or the consultant midwives, doesn't matter, that they're involved in these decisions. And that may also apply to people like the anaesthetist, depending on exactly the nature of the conversation. I had a chat to one of our anaesthetists in preparing this slide. Actually, he told me a load of stuff that's now on another slide. But in essence, the anaesthetist, a bit like the obstetrician, a bit like the obstetric consultant, has a responsibility to balance the workload Their workload is slightly different from ours because it includes the provision of analgesia for women. So it includes putting in epidurals. And one could regard having an epidural as an elective, non-emergency thing. But having had an epidural in labour, I can tell you for free that there was nothing that was non-emergent about that entire episode. And they said to me, oh, well, the consultant anaesthetist who's going to come and put your epidural in is just picking up his curry. And he wants to know, Kate said to me, if he can pick his curry up. And I said, absolutely not. Tell him I'll buy him a curry. He needs to come here right now because I'm going to die. So I think we need to, I'm making light of it, but actually a request for analgesia from a woman is not actually a benign thing, and it's not a non-urgent thing, and it needs to be balanced into this whole equation of what we're doing on the labour ward. But if we have a finite number of anaesthetists, our consultant's already in from home, the registrar's in theatre with an emergency, and then we have another emergency and there's someone who wants an epidural, what comes first? And those decisions and that prioritisation is difficult. And how can we make the anaesthetist lives better? We can involve them in our decision making, so we can make sure that they're there when we're having conversations about them. We think that the woman in room 8 may be going to need a caesarean. We think the woman in room 10 may be going to request a caesarean section. She's asking for an epidural so that they know, and then they're better placed to plan. We're not going to get it right all the time. And yes, there is a risk of them being dictated to either by us or by the coordinator, where we send the anaesthetist to do our bidding. And actually that, like everything in life, is not a very effective way of doing it. And we work much better if we do this as a team. Again, you may have out of hours more junior anaesthetic colleagues who have a different skill set and maybe less experienced with some things and feel less confident with some things. And they may need senior support with some things. And so again, that needs to be factored in terms of the decision making. And again, they will, like all the rest of us, be coloured by their previous experience. I think our theatre team are a completely invaluable resource. We couldn't do it without them. But again, they are absolutely at risk of us dictating to them what is happening. And they have a really important perspective about how to keep that unit safe, how to staff the theatres, how to move women through the theatre in an appropriate flow so that everyone gets looked after. And we may well have unrealistic expectations of how quickly you can mop theatre floor and how quickly you can turn something round. And I think, again, involving them in those conversations, particularly when the labour ward gets busy, so that we do the best job. And, you know, at their core, their job is patient safety. We involve other people all the time. I haven't mentioned our neonatal colleagues except on an earlier slide, but our neonatal colleagues obviously are on the receiving end of the babies, and they have a unit and they have a workflow and they have a certain number of cots and a certain number of nurses, and if those are full and busy, then that is a problem. And again, us having that dialogue about capacity, and particularly us accepting patients in from other places who may be going to have a preterm baby or a baby with an underlying problem, is really important, because simply overwhelming the neonatal unit doesn't help. And they're much better if they're forewarned, and that conversation is often via the neonatal sister in charge. We increasingly, there's a specialty called obstetric medicine, which I deal a lot with because that's one of the main things that I do in my day-to-day job. And so we have physicians, so medically trained doctors who aren't obstetricians. They don't do the delivering of babies, but they work with women, all those women, that 50% of the women are with other medical conditions, and they look after them through their pregnancies. And they're completely invaluable because they understand maternity and they understand obstetrics in a way that your normal renal physician or cardiologist doesn't, because they don't get exposed to pregnant women on a regular basis. And that means that they understand the setting, they understand the labour ward, they know how it works because they've either seen it or they spend all their time with us, so we tell them about it. And they aren't usually directly involved in childbirth. And so that's an important consideration, because the times that we bring them to come and actually stand on the shop floor with us is usually when it's going really, really south, or it's already gone really, really south. And that's important because they're then really out of their comfort zone. They probably haven't been in an operating theatre maybe since they were a medical student. And now suddenly they're in an operating theatre with a woman who's trying to die from whatever the thing is. There's 20 other people there, and we're asking them to be the expert, because actually they have the knowledge and the skills, but then they're out of their depth in another respect. And I think us being respectful of that and understanding that and finding ways to navigate, that's really important. That's even more true if we involve specialties who don't deal with maternity regularly. So Ashok will know very occasionally we call a vascular surgeon, or we call a general surgeon, we call intensive care, we call a cardiologist. And again, invariably that is because something's going badly wrong. And so we parachute them into a setting that's not what they normally do, under a load of stress with lots of people, and it's not an easy thing to navigate, and we need to be mindful of how we involve them. Again, that can happen in the antenatal period as well. If you have non-maternity specialists writing birth plans for women, they can write things that then are completely impossible for Kate and Nadia to enact at midnight on the Oxford Labour Ward. And so we, in maternal medicine, try to navigate that and stop that from happening, because otherwise we just set everyone up to fail. So, as I said, one slide on the law, not a lawyer. So this is the background of medical negligence and when we can be done for it, if you like. So the first thing that came was Bolam in 1957, and I'm not going to go into all the details of the cases because we've got too many things to say. The conclusion was that a doctor can't be found guilty of medical negligence if he's acted in accordance with a practice that is accepted as proper by a responsible body of medical. And use people, not men, it said men. And there may be an opinion that takes a contrary view, but just because there's a contrary view, if a group of people say, we think this is fine, that's okay. He didn't do a bad thing. For Bly, though, the conclusion was basically that in order to be found negligent, you had to show two things. You had to show that A, the doctor did a thing that was not considered reasonable by Bolam. So Bolam is failed in that you did a thing and I don't think that that was an okay thing. No one thinks that was an okay thing to do. And it has to be demonstrated to have caused the harm. So if you've done a thing, but it wasn't the problem, it wasn't the cause of the problem, then you're not guilty of negligence. And then along came Montgomery, which is probably the thing that we're all more familiar with because it's been more recent, even though actually the underpinning comes from the two previous things. And this was a case, Nadine Montgomery was a pre-existing diabetic patient having her first baby. The baby was thought to be large on scan. And the obstetrician who was looking after her in the antenatal period discussed with her an induction of labour, but did not discuss with her the option of having a caesarean in a planned elective caesarean section instead. She was induced, so it went on. She had a rotational forceps birth for which she was consented for, rather than, again, in that scenario, opting to do an emergency caesarean section. And the baby had a very significant shoulder dystocia, which is where the head is delivered, but the shoulders aren't, because the shoulders of the baby impact on the bony part of mum's pelvis. It's a horrible obstetric emergency. It's very, very time critical. And if you aren't able to deliver the baby in quite a short window of time, somewhere between 5 and 7 minutes, then the baby will be short of oxygen. And that was what very sadly happened to Nadine Montgomery's son. And he has cerebral palsy as a consequence of the shoulder dystocia that he suffered. And the judgment in this case essentially said that what had gone wrong was they didn't consent her for the material risks. They didn't discuss the risk of shoulder dystocia with her, and they didn't discuss the alternative options with her, either antenatally or at the time where they decided to proceed with a rotational vaginal birth with forceps. And so the conclusion of the judge in that was that it is our job as medical professionals to discuss the alternatives and the risks that that person might view as material in that circumstance. And that's important because what it's not actually saying, although it often gets interpreted as such, is that you have to discuss everything. It's not saying you have to discuss everything. It's saying you have to discuss the things that are material and that person might ascribe value to. And that's the bit that gets a bit confusing because we have to try and understand what a person might view as relevant. There's been a more recent ruling, which is really important in obstetrics, and I think brings a lot of clarity to McCulloch and brings a lot of clarity to Montgomery and the bits that we worry about in Montgomery, which essentially says, take medical problem A. There are 10 things you might do, or someone's proposed for medical problem A, but actually, 4 of them really aren't reasonable. You're just not going to do them. And even if you sat 100 obstetricians in a room, none of them are going to do those 4. So actually, you don't have to discuss those 4 with them. You don't have to say we could do these things because you really just think they're not reasonable. You know, someone comes to you with a mole on their big toe, do a biopsy from the mole's benign, but the person says, I want you to chop off my foot. I don't think chopping your foot off is a reasonable response to this. It might be reasonable to say, I'll take the mole off for you, do a wide local skin excision, because cosmetically you'd like the mole gone, you're worried about the mole. But in no circumstances what you would do is chop the foot off. So you're okay not to talk to them about chopping the foot off. That's all right. And I think that is helpful in clarifying our role with respect to the Montgomery judgment. And I'm going to stop there because other people are going to do this later. And I'm going to let Kate talk about patient choice.
What do we mean by patient choice? So that's probably become a bigger and bigger and bigger a la carte menu, as you have put a sign on there. As over time, access to information and resources has exponentially increased. The internet, rightly or wrongly, gives people access to information that's both evidence-based and not evidence-based. So birthing people can come with a myriad of wishes, wants, and preferences, which historically probably didn't happen. So the basic ones that we think about all the time is you come and you book your pregnancy and we say to you, where do you want to have your baby? Do you want to go to a midwifery-led unit? Do you want to go to the alongside midwifery-led unit? Do you want to be on delivery suite? Do you want a home birth? Where do you want to have your baby? And we ask people that very early on in their pregnancy before we've established whether they're going to develop any of the lovely things that Alex has alluded to in her decision. And that starts sort of the ball rolling of these are the choices I'm going to start to be presented with in my pregnancy. We then now talk about mode of birth more than we ever probably have done before because of the maternal request cesarean section that has now come in. And people, more often than not, I have conversations with women and birthing people of, if I go into labour, that's fine, I'll labour. But if I don't labour, I don't want an induction, I want a cesarean section. So those sorts of conversations of, is the cesarean section the easy way out? Is it the harder way out? Is it the safer way out? There are lots of conversations that occur through mode of birth, timing of birth, fetal monitoring is another really big one at the moment. And we have had a number of conversations recently following some conversations that I've been involved in of what's better. Do we have a conversation with a woman or birthing person, with members of the MDT present and go, these are all the things that you might be presented with in your pregnancy and in your labour. You might be presented with an instrumental delivery, an emergency cesarean section, a maternal hemorrhage. You might be presented with a shoulder dystocia. Let's discuss every single option that might come up. What are the risks? What are the benefits? What would you be happy to do? What would you not be happy to do? When ideally they are well rested, they're not in pain, they can go away and think about the decisions that you've put forward, but then weighing that up against the fact that probably the bulk of those women and birthing people won't come up against half the things we then have discussions about. And what is the long-term implication of essentially what could be viewed as scaremongering? Because we're saying all these bad things might happen. What are you happy to have happen? But in a lot of these complaints meetings I've sat in, it's more been a case of, I just wanted to know that you had heard what my preferences were and why I had my preferences. So one in particular that stands out is this woman, but she did identify as a female, so I'm going to call her a woman. She said in her birth plan, I do not want oxytocin and I do not want a cesarean section. I will be induced, but I will not have either of those things. And that's when it becomes what some people phrase as a la carte menu. You have to have conversations of, you can't necessarily pick this if you're not then willing to do this, because that puts you at risk that we aren't necessarily doing what is right by you. When we had a conversation with her about it, it then sort of delved much further down to, I think her sister had had some oxytocin and very sadly had an intrapartum stillbirth in a different trust. And therefore she put A and B together and made like Z on there. And those conversations were much easier to have when she wasn't in labour, but time critical elements in labour, it's not necessarily easy to go, I'm going to tell you this, I'm going to walk away for 30 minutes and I'm going to come back. So those sorts of things, the timing of is, you have to consider resources, because Nadia doesn't have 500 hours every single week to speak to every single person about every single option available. But how many people could we see that we recognise antenatally, actually, I can see that you're going to need more information than maybe I'm going to give you at that moment in time, and can we bespoke it a little bit more to those people? Fetal monitoring is another really big one that comes up quite a lot now, although from discussions with midwives working in other trusts, because we have wireless monitoring, it's not such a big thing for us, but there is a midwife I spoke to recently in the unit she's still in, they do not offer wireless CTG monitoring in labour, and therefore they have quite a number of women and birthing people who are declining CTG. I say a number within reason, it's not sort of half of them, because they want to be mobile. They've read that being mobile is really important, they don't want to be attached to wires, and that's something that's really important as well. Examinations is another one, and that comes up probably more, I imagine, in community births and potentially delivery suite, because we are slightly more medicalised, and so it's not quite the same, but I will know when I'm in labour and I do not want to have examinations. And that's absolutely fine. You can't do something to someone that they don't want to have. But what that does mean is that midwife is then having to try and structure at what point do we potentially call this a delay in labour, because we don't necessarily have what we have been taught to use as our ways of managing that. But if you don't recognise a delay in labour, that also comes with an element of complication with further issues, which I won't go into down the line. So each of these areas has a role. Analgesia is another one. The one that's spoken about quite a lot is diamorphine, Meptid, Pethidine. They used to be ones. We use diamorphine now and it's not quite so bad, but people used to go, I'm not having it because I've read that it's going to affect my baby won't breathe, and then I'll need resuscitation. And a lot of it comes from anecdotal, but that's really important. Like the anecdotal and family input in people's shared decision-making is hugely important. People often go, oh, my mother laboured really quickly, so I think I'm going to labour really quickly. Or this happened to my mother, or my mother had a small pelvis, and therefore I don't think I'm going to be able to birth. And that mindset is really, really strong and is really, really crucial when you're doing shared decision-making. Nature has its own ideas. What did you mean by that?
Well, just sometimes you have the best laid plans,
yes,
and then nature does something else.
That's true. So I think patient choice and patient preferences are probably two slightly different things, because it might be a preference for this woman that I spoke about to not want a cesarean and to not want oxytocin, but actually the choice comes down to what can we safely offer you that will ensure that you and your baby are getting the best care that we can. Is there an alternative? Because actually, if we go ahead, which we did in this scenario, and complete an ARM, for example, that's where we manually break the waters, for those of you who aren't clinicians, but we've now started a trail. We've put you on a train that's going to take you from A to B, knowing that you're going to decline certain elements of it. And is that the right thing to do? No, thank you for putting that slide up. That's exactly what I wanted. So there are certain interventions that come with a recommended alternative. So for example, if you have an epidural, our new bowel care guidelines suggests that we highly recommend that you have an indwelling catheter, because we have looked at our bladder injuries and our bladder stretches, Brenda more than anyone probably, and we've decided that actually this is going to be the safest route to prevent that in future. You can absolutely decline having it, but before we put, and I'm not going to do it, but before an anaesthetist cites an epidural, you need to know that this is why we want to give you IV access, this is why we want to recommend this, and are you happy to go ahead with this? And there are anaesthetists who understandably will not cite an epidural if a woman or birthing person won't accept IV access, because they're doing something they know might require that, and therefore they will say no. And I think there is very muddy water here, and it's ensuring that actually the shared decision making, it's hearing every single person's voice and sort of getting to the nitty gritty of why you're going to decline this, because actually very often with a good bit of counselling, it's fine and people will recognise it. Or if they don't, you can then create plans that are safe for those people. I won't go into all of but the general theme is, if you do one thing, you can't do it without this thing most of the time, or it's not recommended without this thing.
So how do we deal with patient choice, shared decision-making, safety when we're managing multiple patients? So we have multiple patients insofar as we have got a number of pregnant patients in the region. We've got a number of them on our lay ward. We have more on our antenatal ward. So there's a cohort we need to look after. And then each of our patients has a baby who is, if not now a patient, will be perhaps to our neonatal colleagues later. And so one of the ways that we manage our workload is prioritisation. We've got a picture of an air traffic control station here. Because the way that we can, well, one way we can think of our labour ward is if we've got one runway on our airport, and we've got a flight coming from Singapore, and we've got 5 coming from Europe, and we need to decide who's going to land first, except that the last flight didn't land very well. They had to resurface some of it. There was a minor fire. And now we've got some planes circling, and we need to decide who's going to land first. And we know that the one that's come from Singapore is probably running a bit short on fuel, so we'll probably plan that one first. Problem is, the plane from Edinburgh has got a bunch of people in it who have a very real fear of flying. And the 45 minutes that they can manage is up. And now the plane is kicking off. It's not a nice place to be. People are very uncomfortable, and it's causing a lot of very severe distress to a lot of people on that flight. But we've decided, Singapore can first, and then the Edinburgh flight will come. The problem is that the flight from Madrid has now got a patient having a medical emergency. So that one's probably going to have to trump really both. But that's fine. We'll get the Madrid plane in, and then we'll get the Singapore plane in, and then we'll land the Edinburgh plane, as long as there's not another minor fire, because we didn't properly sort out the fire when it happened, because we needed to use our runway again faster. So we sort of half sorted it, and then it flared up again. And by now, all hell has broken loose on this flight. In an ideal world, we would have 5 runways, and then each person can land, each plane can land exactly when they want to and how they want to on that runway, but that's not always how it works. So we have to be careful about what comes first. We have to try and plan ahead, accepting that sometimes there might be an emergency, and so you don't want to block your emergency exit, which often in obstetrics is our operating theatres. So the runway is our theatre, and oftentimes we are trying to manage the workflow through the number of theatres that we have. Time is another concept that is bent on a labour ward. It does not always occur in the same way that we think it does when we're not on a labour ward. People need time to make decisions. To make decisions that are difficult, people need a bit of time and a bit of headspace to do that. And unfortunately, often we can give them that time, and often we can't. And so some decisions are time critical. Sometimes whatever is happening so fast that we need a decision, and we need it quickly for the safety of the person making that decision. Sometimes we had a space on our runway, and we can help offer you to land on the runway right now. And in the time that somebody fairly and rightly needs to think about it, unfortunately, some other planes have come into problems and need to land on the runway first. And this means that it can be difficult for people when they are making decisions to not come under pressure, to make it quickly and to be able to think about all of the things that they want to in order to make the best decision for them. We can go to the next. The other aspect of this to think about is how it affects health inequalities. We've talked a little bit about this, but in our, well, really all of our statistics, but those that we look at the most are the mortality statistics for mums and for babies. And in all of them, we have really big differences between different groups of patients. And so, for example, Black women, 4 times more likely, although they're slightly better on the most recent Embrace reports, that it's about 3 times more likely to die in childbirth than the average in the UK. Similarly, women from the most deprived areas are twice as likely to die as the average, and they're much more likely to die, than those from the least deprived areas of the UK. So these are things that we need to think about, especially when we're talking about shared decision making. Are some voices louder than others? I think, well, we know that there are factors that influence how somebody communicates their preferences, whether they're able to communicate them, basically how loudly they shout or how loudly they talk. I think that probably equally, if not more important, is how we hear them. So what factors we can do to help everybody have their voices heard? How do we empower people? How do we cross the communication barriers to make sure that everybody's voice is heard in the same way and with the same weighting? And that's something we're not always good at in maternity, but it's probably key to addressing some of these inequalities. This is a story about a patient who wasn't believed, basically, when she was in pain after an epidural. And this causes a huge amount of birth trauma to people when they're in a lot of pain, but in particular when we don't acknowledge or disregard the pain that they're in.
Who takes responsibility for birth? That's a very good question. I would say overall responsibility stands much like at the end of the day, the buck stops with the consultant. But we do have a consultant midwifery body who run our out of guidance criteria clinic, so to speak, or our birth choices clinic. And it is getting increasingly busy as time goes on. And they've had to open it up to more people. In fact, we just advertised for more out of criteria sort of birth choices clinic midwives. What's involved in the decision? Well, normally I might come to Sophie, our consultant midwife, and I'll say, I've had 4 previous cesarean sections, but this time I'm going to give birth at home in my pool, and midwives can come, but they have to stay outside the room, and that's what I want to do. And Sophie will listen to everything I bring forward, and what she'll normally start with is, why? Why do you want to do this? What happened with your previous births? Why do you now want to be at home? There is always a why to everything that someone brings forward, particularly when it's out of guidance. People don't normally make these decisions because they want to have a difficult time. They normally come to the really robust and very, very valid reason. And the first thing to do is look into that. What resources can we pour in? Do you need help from our psychology team? Do you need help from our anaesthetic team? Do you need help from our mental health team? What team do you need support from? We then, what we need to look at is, how do we make the safest unsafe decision? So very often, the next thing that might be offered is, would you consider coming and labouring maybe on our alongside midwifery-led unit? So it's still out of guidance, but providing the lifts are working, you're only a lift ride away. I can't even guarantee you that'll happen, but in theory, you're only a lift ride away. And would you maybe accept a cannula to be up there? And that gives people some time to think about that. What does that mean? Sort of those bits and pieces. And then she might go, in this example, yeah, okay, fine, I'll do that, I'll go there. And I go into labour at 1 a.m. and Rihanna is the midwife on her own on the Spires. She reads my birth plan that she's had no involvement in writing whatsoever, and probably doesn't feel that happy about it, because I probably would feel quite uncomfortable having previous 4 cesarean sections on the Spires. But that's how it tends to work. And for some reason, and there probably is an element that we need to look at, out of criteria births are quite top heavy in the way decisions are made. They very much come from our most experienced people, which is probably why, because our consultant midwives are very well read on all of the up-to-date evidence, our consultants know element of previous experience, etc., etc. But actually, the responsibility for providing that labour care tends to fall to some of our most junior midwives. Not that Rihanna is a junior midwife, but that tends to happen. And it will be potentially the band 5, because that's the only midwife that's left on that day. And that is an immense amount of responsibility for something that is hugely complex, that people have had no part in making that decision, to then ask someone to provide the best shared decision-making care they possibly can. But it happens more often than not. And I think sometimes that part, the shared decision-making, is missing. I think it's a really crucial element that we do not give enough voice to. We've given voice to me, who wants the out of criteria. I've given voice to the consultant midwife. It's probably gone to maybe Alex or Nadia, and they've gone, yeah, okay, she's made the safest unsafe choice. And that's all great. You write a really lovely plan. This plan is based on a Monday morning when everyone else is around. But in reality, that doesn't happen. And the person we don't give a voice to in the shared decision-making is that midwife who is going to end up providing that care. Now, in theory, Rihanna can go, I'm not going to do it. I'm not going to do it. It's not for me. I'm not having it. And then the coordinator on that shift is then going to go to all the other midwives and go, which of you is happy to provide this very out of criteria home birth that's now up on the Spires? And in amongst all of this woman is probably not getting the best care, because what we're doing is trying to find someone who's going to give it. But that is the reality, the bread and butter of what out of criteria birthing looks like to us on the front line, shop floor, whatever sort of conversation you want to have about it. And I think it shouldn't be, there's not enough weight put on how challenging that is for everybody involved, including the birthing person who believes they have had this really robust plan put in place, and it appears to them it's crumbling in front of their very eyes. And that then leads to a cascade of potential intervention, because they haven't got what we thought would happen. And I don't know what the solution is to that right now, but it's something that needs to be considered a little bit more, I think. This is me too.
This is you too, but I mean, you've just done.
Well, staff psychology safety is really important because if you keep people safe, keep staff feeling safe, they keep coming back to work. And none of us are ignorant to the staffing issues we have in maternity at the moment, and the rise in absences and sickness due to work-related stress is high, and it rises all the time because more and more decisions are being made that are not within the norm of what we expect, and the responsibility we've put on people without the additional training is quite immense. We do have a staff psychology team who are excellent, but they are a small team. We have over, I think last time we checked, about 500 to 600 midwives within OUH alone. That's not including our support workers, our doctors, our sort of theatre team, etc., who all need to feel equally as safe when they are providing this care. But if you can make staff feel safe, and it might all be that the coordinator calls Brianna and says, what is your issue? How can I make you feel safer? If I send you up someone as soon as you think she's fully and can stay with you the whole time, does that make you feel safer? And Brianna might go, yeah, that's fine. I feel better about that now. Or I want her reviewed by Nadia before we do this to make sure. And whatever we can do that makes that better enhances care and shared decision making whilst keeping staff coming back to work. Very important.
This is
that
yeah.
These are, I think she's already explained it all, the ways that we can support staff in promoting shared decision making, psychological safety, debrief, etc., etc. Keep scrolling. Oh yes, why does shared decision making matter? Well, it matters because we have the potential to create a lot of trauma in maternity. It's very real. Trauma, PTSD, often we've caused or contributed to it. And actually, often it's not in the complicated shared decision-making ways that we think. It's often really basic things, like being dismissive of patients' concerns, ignoring their requests for pain relief, not explaining to people what's happening at the time it happens, examinations, procedures without proper consent. 4 to 5% of women who give birth develop PTSD. That percentage is higher for patients that are in a very medicalised setting, like a labour ward. 1% of birth partners develop PTSD, and we don't really think about that very much at all in maternity. Keep going. Perfect. And what's the impact? Well, birth trauma can cause difficulties bonding with babies. It can cause patients, particularly if they develop PTSD, to avoid contact with healthcare professionals, including in future pregnancies. It can make it very difficult for them to then come back to the place where they received that trauma for more care. I think it's very easy for us to say, well, why does she want to have a home birth after cesarean section? But if we've caused PTSD or contributed to it in the way that we've treated this person, it's logical that they won't want to come back to that environment again. It can cause relationship difficulties, physical problems, and PTSD we've talked about. There is a birth trauma inquiry, parliamentary inquiry going on in the UK at the moment, so it's all very topical.
And I also think, sorry, just to add to that, there's a really niche group of people that are midwives, doctors, MSWs, who get quite sick, like a particular type of birth trauma, because then what we expect them to do afterwards is then go back into their place of work, which is exactly this. If you are a midwife who maybe has a 20-week loss and then you don't get maternity leave and then you have to come back for financial reasons, but the area you come back into is providing care for other people, that's really, really harsh. Or if you give birth and you have trauma from your own birth, it's a really niche element, particularly because shared decision making with a clinician that is specialised in that area is a whole new type of shared decision making. Yeah. And I think it's something that's really worth giving some speech time to.
I'll talk briefly about staff factors that contribute to birth trauma. Groupthink, when we all collude and think in the same way because we've all trained the same way and we all work together. The grey area, the grey area or the grey zone is one of my favourite analogies to use, because I think we all feel quite happy in the green zones. That's our comfort zone. That's where the policies are and the guidelines are. And we know our red lines. We know what is a hard no. So we know when I'm not going to, I don't know, prescribe oxytocin, or whatever it is, I don't know, there's some red lines. But actually where much of this decision making is happening is in a grey zone in between. And our patients, just like us, they have green lines and they have red lines, but much of the decision making is happening in this grey zone. I think for all of us, it's probably helpful to be a bit more comfortable and a bit more familiar with venturing into the grey zone and meeting patients where they are and going from there. Okay. So what can we do to prevent birth trauma? So antenatal education, I think we have a slide on this, we don't need to go into it in too much detail, but we really want people who are about to embark on childbirth to have access to really robust and accurate information so that they can make informed decisions that are the best decisions for them. Informed consent, now everybody knows about informed consent. What I think we as obstetricians need to think about is that we have some serious tools of coercion when it comes to making decisions in childbirth. We take a healthy person, usually a woman, we make her as sleep deprived as we can, cause hours and hours of pain, and in that moment we come in and ask her to make a difficult decision. And one thing I think it's important to understand about informed consent is that she can have spent 9 months saying no, and all I need to hear is one yes, and that's it, the decision is made. And so I think we talk about informed consent as if we sit down in a clinic and we say, this is what we could do at this moment in time. That's not what happens at all. We put someone under a huge amount of time pressure on top of her pain and her sleep deprivation. We can, if we really want to up the ante, throw some things at her, like your baby could die or be brain damaged, if we really want to push her into making the decision that we want her to make. These are things that we should say for when it's actually true. I think that sometimes we can, in our own anxiety, I don't want to say threaten, but use these sorts of expressions to get people to agree to what it is we want them to do. But that doesn't make it the right thing to do. So sometimes, yes, we're in a situation where that's warranted. A lot of the time, I think perhaps it's not. But I think also being mindful of the state that the person is in the moment you're asking them to make what is a very difficult decision. Listening to concerns and understanding what's driving their preferences. In particular, I find it useful to look at what their perception of all of this was before that moment when they're tired and they're sleep deprived, because it helps you get an idea about what's important to this person. Offering pain relief when requested, informing women of their choices. They have choices always, and informing them of their choices. And also, what does that look like? Because I think it's really easy to say, we can do this or we can do that. But what does that look like? What does it look like if we do nothing? What does it look like if we do a ventouse delivery? What does it look like if we do a cesarean section? Explaining what's happening and of course showing sympathy when women are distressed sounds easy, but I think in the middle of a busy shift where someone is being difficult, I think sometimes compassion fatigue is real and people are a bit cold and a bit heartless in the way that we talk to patients about this stuff. We're nearly done. Antenatal education, I mentioned we want robust access to patient education. Often people are getting it from social media or websites that might not have the best evidence-based information. We don't go into too much detail, we'll run out of time. Patient advocacy, this is on all of us. I think there's a tendency in obstetrics to think that midwives are advocates for patients. Well, we're all advocates for patients, and our goal should be in allowing this patient to speak up, to use their voice, to be able to say the thing that they're worried about saying. Collective decision-making, supporting the patient support system to help her make that decision, having open and honest conversation. Human factors, we talk about that a lot in maternity, how we interact with each other. And then finally, decision-making, patient wishes, communication, psychological safety for everybody involved, including the patient, collective decision-making and sharing the responsibility, involving partners, birth partners, and for our own workforce managing hierarchy.